Good morning, everybody. Today, I'll be discussing about, I'll be presenting on watch and wait approach for locally advanced rectal cancer. This is an area of recent interest among the colorectal surgeons, the oncologists, and the gastroenterologists. In spite of all the interest, there has been significant controversies around this approach for locally advanced rectal cancer. So, by definition, locally advanced rectal cancer is either T status T3 or T4, that is tumor penetrating the rectal wall, with or without N1 and N2, that is involvement of regional lymph nodes up to 6. And there should be no distant metastasis. So the treatment of locally advanced rectal cancer has come a long way. In the initial good olden days in the 1970s and in the early 1980s, surgery is the only modality of treatment. Then because of significant local recurrence rates, there came up a study which established adjuvant chemoradiotherapy as the dictum. That is, after surgery, subject these patients to adjuvant chemoradiotherapy to improve local recurrences and increase the disease-free survival rate. Then came in 1986 a concept of total mesorectal excision in surgery. This has revolutionized the surgical outcomes. According to this, the rectum is removed in total with an envelope of mesorectum. So this will be able to take care of any satellite deposits in the mesorectum, thereby increasing the disease-free survival in the local recurrences. Then till 2004, there came up several studies. Out of these, there are 3 outstanding studies: the Swedish rectal cancer trial, the Dutch trial, and the German rectal cancer trial. These 3 studies together established neoadjuvant chemoradiotherapy as the dictum. That is, subject the patient upfront with neoadjuvant chemoradiotherapy, then surgery, then chemotherapy to decrease the local recurrences. And there came in 2004 a landmark publication by Habergamma on non-operative approach, which I'll be discussing. So at present, according to the NCCN guidelines for locally advanced rectal cancer, the standard treatment is neoadjuvant chemoradiotherapy, then surgery, then adjuvant chemotherapy. So what does this neoadjuvant chemoradiotherapy help in? It helps in decreasing the local recurrences by decreasing the size of the primary tumor. So at the end of surgery, there will be increased R0 resection rates. What the data showed is that incidentally in all the resected specimens, when they have subjected to histopathology, around 10 to 30% of specimens have complete pathological response. That is, there are no tumor cells detected. So this approach is questioned by Habergamma. So she proposed that because 10 to 30% of patient has excellent outcomes with no tumor cells, why should we subject these patients at all for surgery? So she is a colorectal surgeon from Sao Paulo, Brazil, and this is the landmark publication which she has published in Annals of Surgery in 2004. So it is operative versus non-operative treatment for stage 0 distal rectal cancer following chemoradiation therapy and its long-term results. So there are around 265 patients which were included in the study from 1991 to 2002 prospectively. All these patients were subjected to chemoradiation and the outcomes were studied. All the patients were vigorously subjected to surveillance by digital rectal examination, serial CEA levels, colonoscopy, and imaging. And the median follow-up is around 57 months. So out of all 265 patients, 93 patients fell into the category of stage 0. And in this, 26% of patients has complete clinical response. So these patients were categorized as observation group and they were not offered surgery. They were only managed non-operatively with a good surveillance. Whereas 8.3% of patients who fell into the stage 0 had incomplete clinical response and they were termed as the resection group. So when they compared head-on both these groups, she has identified that the systemic recurrences were similar in both groups. Only 3 patients had systemic recurrences. And in the observation group, 2 patients has regrowth. And the 5-year overall survival is 100% and the disease-free survival is 92% owing to the regrowth. Whereas in patients with the resection group, that is by definition, because they had an incomplete clinical response, they are the patients who are having an aggressive tumor biology. So their 5-year overall survival is only 88% and the disease-free survival is 83%. So initially, when she started this study, she has faced a lot of resistance in her own institution and she was criticized for starting the study. And when she published this paper in the global forums, first in United States, she was questioned by the audience, and she was not even allowed for any discussion and dismissed from the podium, stating that this is completely an unethical practice at that time. But she continued with her own data and observation for non-operative approach. So even after this study, the standard treatment as per NCCN is neoadjuvant chemoradiotherapy, surgery, and then adjuvant chemotherapy. So what are the drawbacks of this standard treatment? So there are significant quality of life issues when patients are subjected for rectal cancers surgeries. So they had sexual dysfunction and bladder dysfunction and anterior resection syndrome. So during total mesorectal excision surgeries, we also do lymphadenectomy going up to the inferior mesenteric artery root pedicle. So whenever there is significant lymphadenectomy done, the autonomic nerves around the IMA pedicle plexus are injured. So these patients eventually develop sexual dysfunction and bladder dysfunction. There are some surgeons who went on to the extent saying that if after rectal cancer patient is not having bladder dysfunction and sexual dysfunction, your surgery is not optimum, though this is criticized by many. And as expected, all rectal surgeries has significant morbidity because of major surgery. It being major surgery, there are significant surgery related complications like anastomotic leak, stoma related issues as well. If the tumor, distal rectal tumors are involving the sphincter complex, we need to go for complete abdominoperineal resection, and these patients end up in having lifelong colostomy. If we are able to save the sphincters, these patients end up having low anterior resection surgeries with ileostomy. So these patients are bound to have ileostomy related complications, though they are temporary. And in some data showed that the perioperative mortality in these patients is up to 2%. And other drawback is, even after this standard neoadjuvant chemoradiotherapy, the local recurrences have decreased, but it was not able to address the distant recurrence rates. The distant recurrence rates still remain to be around 25%. And 60% of the patients, when the data is collected, around 60% of the patient did not receive adjuvant chemotherapy at all, because owing to surgical complications like wound related issues where we cannot start chemotherapy, and also because of poor compliance. So as said, in the initial stages, the local recurrence rate is up to 30 to 40%. With improvements in neoadjuvant chemoradiotherapy, the local recurrence rate has decreased to 4 to 8%, but the distant recurrence rate remains same at 25%. This led to the evolution of the concept called total neoadjuvant therapy. It is more coming to picture from 2018 onwards. There are several trials, important trials, the timing trial, OPRA trial, Rapido trial, etc. So what exactly is total neoadjuvant therapy? So the chemotherapy which is given after surgery is now pushed before surgery, and it is completed. All the chemotherapy and radiation is completed before surgery. After surgery, there is no treatment left in these patients. So there are two types of total neoadjuvant therapy. One is induction chemotherapy, the other is consolidation chemotherapy. If chemotherapy is given first, then chemoradiotherapy, then surgery, it is called as induction chemotherapy. Whereas if chemotherapy is given after chemoradiotherapy, it is termed as consolidation chemotherapy. Compared to both induction chemotherapy and consolidation chemotherapy, patients with consolidation chemotherapy has better results. Why? Because when we give chemotherapy first, there are some radio-resistant clones which are developing, which are very resistant to chemoradiotherapy. So the local recurrence in these patients was high. So out of these both therapies, consolidation chemotherapy has a better outcomes. So what are the benefits? As discussed, total neoadjuvant chemotherapy, it decreases the risk of systemic failure and distant recurrences by addressing the microscopic tumor deposits even before surgery. And also number of patients being compliant and completing treatment is high. Because no chemotherapy is left after surgery, these patients have even shorter ileostomy time. So what are the outcomes? With standard therapy, only 20% of patients has complete pathological response, whereas once we follow these total neoadjuvant strategy, almost the pathological response went to as high as 40 to 60%. And as expected, the systemic recurrences were less, up to 5%. So there are two major trials which recently have established total neoadjuvant treatment as the modality of choice in patients with advanced rectal cancer. That is the Rapido trial and the Prodigy trial. One has followed consolidation chemotherapy, one has followed induction chemotherapy. But Both these trials have shown that the pathological complete response is around 28% compared to the historical 14 and 12%. So if we combine these two approaches, that is the outcomes of total neoadjuvant therapy plus the wait and watch approach of Haber-Kama protocol, they have seen that the main rationale is total neoadjuvant therapy has good pathological outcomes up to 40%. So why should we subject these 40% of patients at all for surgery, so that we can avoid quality of life issues and reduce over treatment? So this led to the evolution of the concept, the present concept of wait and watch approach. So there is only one trial which has integrated both wait and watch approach and total neoadjuvant strategy, both together in this trial. This is the first prospective randomized control trial. We have only 3 years data till now. The 5 years data is yet to be published this year. So this was published in 2022. Only 3 years data is available. Out of total 324 patients of locally advanced rectal cancer, 158 received induction chemotherapy, 166 received consolidation chemotherapy. Then they were restaged. After restaging, they have termed response as complete response, near complete response, and incomplete response. If patient has a good complete response or near complete response, they were given non-operative management. And if patient has incomplete response, they were directly subjected to surgery. So what they have seen that a whooping 74% of patients in the study went for wait and watch approach. So when they studied the data of these 74% of patients, they noticed that up to 50% of patients at the end of 3 years were able to preserve the rectum and avoid surgery. So suppose if we have, yes, and among this data is only among the wait and watch approach group. So to summarize, the wait and watch approach group, 50% of patients are from the consolidation group. The long-term data is not yet out. The 5 years data is supposed to be published this year.
P-value difference between the induction and consolidation?
There is p-value difference in patients with for rectum preservation of the rectum, that is organ preservation strategy. If we apply, 53% is in the consolidation group, so the better than the induction group. They have to compare this again with patients with who are subjected to TME.
So this study is contradiction to the previous data. That means the induction is faring worse than the consolidation.
It is in line with this.
Okay.
Consolidation was better in this, and this.
The data previously you showed induction group did better.
One trial has showed, Prodigy trial has showed that induction did better, whereas Rapido trial has showed that consolidation did better. So there is a controversy between both trials. So suppose if we have to integrate this wait and watch approach in clinical practice, how to go about? First important thing is patient selection, then assessing the response, then follow-up, and we should also understand what are the challenges involved in following this non-operative approach. So coming to patient selection, we have to inform the patient that this is an organ preservation strategy and it is not a standard approach. It is to be applicable only in patients with distally locally advanced rectal cancer, that is the rectal cancers which are around 5 to 7 centimeters from the anal verge. This is not applicable or fair enough for patients who are having mid-rectal growths and upper rectal growths. So the initial evaluation is according to the standard NCCN guidelines that each patient has to undergo a baseline endoscopy and biopsy, and they has to undergo MRI rectum to assess the T status and CT scan chest and abdomen to rule out any distant metastasis. So all these patients should be subjected to total neoadjuvant therapy. Once total neoadjuvant therapy is completed, there should be a multidisciplinary discussion, and the patient should understand that non-operative management is not at all the standard approach, and it is as a clinical trial, as a part of clinical trial, or as a novel approach with no long-term data available. And compliance with an intensive surveillance protocol is mandatory in these patients. So when we assess the response by digital rectal examination, endoscopy, and MRI, there are 3 categories. One is complete clinical response. Second is near complete clinical response, and the other one is incomplete or no response at all. So NCCN has defined both clinical complete response and near complete response. So the upper picture showed the image of a patient who has upfront advanced rectal cancer. So the lower images were of the same patient after neoadjuvant complete response, which showed complete clinical response. So according to this, when we do digital rectal examination, there will be a smooth or flat scar and there should not be any nodularity. Whereas on diffusion weighted MRI, there might be fibrotic linear scar with low signal intensity on T2 weighted images. There should not be any diffusion restriction and there should not be any suspicious lymph nodes. And on endoscopy, there should not be any residual stricture. There should not be any residual ulceration, nodularity, or mucosal irregularities. But presence of a pale smooth scar with or without telangiectasia is also included in this as a complete response. And NCCN, it has defined near complete response as if on digital rectal examination, we could feel a minor mucosal irregularity, or on endoscopic examination, if we could see these irregular small mucosal nodules along with superficial ulceration or mild persistent erythema. And on T2 weighted images, there will be significant downstaging of the tumor, but there will be a persistent residual signal with complete or partial regression of lymph nodes. And diffusion weighted images show a small area of residual or high signal intensity. So this is the image of the patient before neoadjuvant chemotherapy. And this is the lower image is after neoadjuvant chemotherapy, which showed a near complete response. So following the OPRA trial, even the NCCN guidelines have taken into consideration the results of OPRA trial, and they have categorized the responses as discussed as a complete response, near complete response, and incomplete response. Suppose if patient has complete response or near complete response, they were given the option of wait and watch approach. This is purely an option, but it is not mandatory that these patients should be given wait and watch approach. But if patient is having incomplete response, all the patients should be subjected to surgery, that is total mesorectal excision. So how should we follow these patients? The data has showed that in patients who are given the option of non-operative approach, the regrowth rates are highest in the first 2 years. So they should be serially followed by digital rectal examination, endoscopy, and CEA. In the first year, they should be done every second monthly, and axial imaging should be done every 6 monthly. In second year, we can do these examination, digital rectal examination, endoscopy, and serum CA levels every 3 months. But axial imaging, irrespective of whether there is a growth or not, it is mandatory and to be done every 6 monthly. At any point, if there is any suspicion, these patients can be subjected to PET-CT as well. From third year onwards, these patients will require every 6 monthly evaluation and so on. So around 25% of the regrowths has occurred. All growths have occurred in the first 2 years. So the intensive protocol is in only the first 2 years. Beyond second year, it is always 6 monthly evaluation. But the data as of now is very preliminary. We need more data in the long term to exactly strategize how we should follow up these patients. And the major challenges involved, or whatever the response assessment, is all subjective. So we need more objective criteria to assess this response. And there is always a dilemma with near complete response. The data has shown that in patients who are subjected to non-operative management, 25 to 30% have regrowth. When patient is having regrowth, immediately these patients are to be subjected to chemotherapy. These patients should be directly subjected to surgery. In patients who are having regrowth, the rate of distant metastasis is high compared to patients who are not having regrowth. So the major dilemma or the challenging group is the near complete response according to both the OPRA trial and the NCCN guideline. This is a gray area. Suppose this is a picture which is before total neoadjuvant therapy. Once we complete the total neoadjuvant therapy, patient might have near complete response. Now, if the patient is having near complete response, should we subject these patients for surgery or should we subject these patients for wait and watch approach? So they might either have a complete response in the second assessment or they might have a regrowth in the second assessment. Because the chances of distant metastasis are high when the patients are having regrowth, it is always heroic to subject patients with near complete response to non-operative approach. So nowadays, there are some novel tools for assessment to make it more objective, but this has not been incorporated into the clinical practice, like using dynamic contrast enhanced MRI, radiomics, molecular markers, and circulating tumor DNA. There is no data on these, on implementing these features. So this is one case which I would like to discuss, which we have managed at our hospital last year. So this is a 46-year-old male who presented with bleeding per rectum. So when we did standard workup and colonoscopy, we found a mid-rectal growth, which is ulceroproliferative region and compromising up to 50% of the lumen. On imaging also, we could clearly see that there is significant thickening of the rectal wall, both in CT scan and MRI with significant luminal narrowing. So this patient, after discussion in the tumor board, was subjected to total neoadjuvant therapy instead of the standard approach. Unfortunately, this patient did not complete the total neoadjuvant approach because of poor compliance. He missed one cycle of total neoadjuvant approach. So in spite of that, when we assess this patient 6 months after his primary assessment, to our surprise, we found that there is significant response in this patient. Only except for a small nodule at the periphery and a small scar, there is no tumor seen in this patient. But on imaging, both CT scan and MRI showed the significant thickening of the MRI. So we cannot actually say whether this thickening is related to the residual tumor involvement. Biopsies showed no growth at all. But in spite of this, so this is a clear near complete response. It doesn't completely fall into the category of complete response because of the residual nodule present at our second assessment. So this patient is quite educated and he has done a lot of research by himself. He went on to the extent of reading NCCN guidelines and he wanted to go for non-operative approach. But we did not agree with this approach and proceeded with surgery. And he underwent laparoscopic low anterior resection, colorectal anastomosis, and defunctioning loop ileostomy. After 6 to 8 weeks, we closed his ileostomy. Patient is now doing well. What are the main reasons why we have not gone for wait and watch approach or non-operative approach in this management? Is this is predominantly a mid-rectal tumor. So our follow-up assessment by distal rectal examination cannot be done in this patient. So ideal would be only distal rectal tumors for this approach. And also there is age consideration. This patient is only 46 years of age. So there is no data and how long we have to follow these patients for surgery or wait and watch approach. And when we assess the response, endoscopically, there is a good response, but radiologically, this response is not correlated. There is significant thickening of rectal wall in both MRI and CT scan. So to conclude, we don't have long-term data yet to confidently say that, yes, we can follow wait and watch approach in all patients with locally advanced distal rectal cancer who has good response. The 5-year result of OPRA trial is pending, and there is now an international wait and watch database, which is started in 2014. Total till now, around 2000 patients were recruited and they are being followed up. And we should understand that this is not at all the standard approach. Surgery is still the standard approach for all patients with rectal cancer. And we should keep in mind that clinically, even though there is a response, this cannot translate into pathological complete response. We need more objective reassessment criteria. And if the patients are subjected to wait and watch approach, these patients have many psychological issues like the fear of impending, that they don't know when is the tumor going to recur, what happens in future, if they have suddenly a distant metastasis. All these are the fears which the patient has to deal with. These are my references. Thank you.
Thank you.